Right, case orders. Everybody stand up, have a little shake, because I think it's time we all had a little move. Yeah, I think a dance would be fine. Yeah, Miloslav, if you want to lead us all in a dance, that would be great. Yeah, come on. Yeah. A good start, yeah.
Cut some ribbons.
Should we cut some ribbons as well? Yeah. Okay, everybody got their legs moving? Blood going? Yeah, that's fine. We'll do this in between the next one as well.
Great physio, Judith.
Thank you, Kay. Honorary. Okay, right. So I'm Judith, as Jeff said, and I'm from Cardiff University in Wales. I haven't actually got a map. I feel really gutted that I didn't provide a map. Heather hasn't got one either. That's really good. Okay, but we're in Wales anyway, which is sort of like the left-hand side of the UK, and Cardiff is the capital. So I just wanted to say good morning, bore da, which is Welsh, and I got to pronounce Brno. Does that do? Okay, good morning. Thank you. This is better than a map, isn't it? Okay. So I just wanted to return you to the JBI model. So we're all familiar, I'm sure, with the JBI model of evidence-informed healthcare. And what we're doing this morning is focusing very closely on this little bit here, which is evidence implementation. And it's been, I think, we now know that what's happened is that we're all great at doing research, we're all great at doing systematic reviews, but what we absolutely struggle with is this last bit. Getting the implementation, getting the evidence into practice. So it was great hearing Mighty's presentation. The work she's done in Spain is absolutely incredible, because unless we get that evidence out there, then what is the point of any of the research we do? So for me, this is the most important bit, is the evidence implementation. We're all familiar with the original Sackett's evidence, definition of what evidence is, but it's about that conscientious, explicit and judicious use of evidence, and it's about our individual clinical expertise, it's about the available clinical evidence, but it's also about that individual patient. And you'll see the updated version by Zoe, who was obviously the sort of head of JBI, and she said that one of the things is really important is context. And we have to consider context in everything that we do. So we've now got all these different types of systematic reviews. So these are our JBI sort of amount of different systematic reviews. So you can see we've got effectiveness reviews, we've got prevalence, we've got diagnostic tests, we've got scoping reviews. So we've got loads and loads of different types of reviews. But what do we do for this next stage? How do we get this implemented? So this presentation is focusing on context, so a little revision of what we mean by context. What does it mean? So this is the dictionary definition. So the noun, it's a noun and it's the cause of the event. It's the situation within which something exists or happens, and what can help explain it. So why do things sometimes work and why don't they work? So some further definitions, and Bridie referred to the Health Foundation. So the Health Foundation, I really like this definition. I think it's lovely. I think it's sort of pictorial, it explains what it is. And what they say, if an intervention is a seed, then the context is the soil. And you might all remember that hymn about planting your seed and it falls on stony ground and it doesn't grow. I don't know if you all remember those. It was an old one we used to sort of sing when we were young. But there's no point in having a seed if you don't plant it in the correct context. If you plant the seed on stony ground, if you don't water it, then it won't grow. So you need to think about that soil, that context. And it's the interaction between the elements that makes any improvement successful. So it's what you do, it's the intervention, what you do, it's also how you do it, how you implement it, and also, very importantly, the environment or context that you do it in. And all those three things need to happen for implementation to be successful. So it's a bit like chemistry. Yeah, it's that chemical reaction. So you have those substances, reactants, they're converted to different substances, those products, and they only happen when you've got a given temperature and you've got that chemical concentration. And that's the context. That's what we need to think about. But I think it's actually more complex than chemistry, and chemistry's hard enough. It's a bit more complex. So we know that there's a weak relationship between the strength of evidence base and behaviour change. That's well established. And in order to think about context, there's lots of things you need to think about. So whenever we think about behaviour change, we need to think about both external and internal influences. So I just put some further reading on there, so have a visit for this. This is the Health Foundation document, Perspectives on Context, and they talk in detail about all the different influences. And there's a lovely little quote in there that says, the notion of context, as it's used in the social sciences, is not a strictly theoretical concept, but rather a more or less fuzzy notion. And it denotes both the situational, the historic, the geographical, the social, and the cultural environment of that phenomenon. So we need to think about all those different things. And these are some of the potential influences. So you can see, for external influences, might be your local policy. I'm sure Mighty's familiar with all these as she's been implementing in Spain. The resources, professional influences, necessary equipment. So recently I've been doing work in Zambia, and we've been setting up with the School of Nursing in Zambia. They wanted to develop an evidence-based ward. So we've been thinking about, we've been actually using the PDSA cycle to do that, to set up this evidence-based ward. And one of the things they were really keen on was infection control, which Heather will be familiar with. But actually, how can you do infection control if you haven't got any sinks on the ward and you can't afford the hand washing gel? Yeah, so there's no point in all the policies and all the guidelines if you haven't got that equipment. So that was one of the first things we had to think about. And then you've got your internal influences. So the skills of your staff, your group psychology, ownership of the project. So what we've been using is what we call a sort of co-production. So we've involved everybody from the bottom up. And ideally in co-production, you involve your patients, your service users, everyone is involved in the whole of that project. So success comes from involving everybody. And Bridie mentioned some of the implementation frameworks. So this is the original Paris, which Bridie mentions, is about implementation, evidence, context, facilitation. But these frameworks, as Bridie mentioned, have been really difficult to test. So how do we know that they actually work? And how do we know it's evidence? So we talk about evidence, and surely evidence is evidence, isn't it? Or is it? So let's think about a couple of scenarios where context really has an influence. I have to say, I stole this one. It's about measles, where I went to a presentation some years ago with the great Sir Ian Chalmers from Cochrane, one of the original founders, and he was talking about measles. And when he qualified, he went to work in the left bank in Palestine. And he said, they were giving antibiotics to children with measles. And he was saying, well, actually, you know, measles is a virus. We don't give antibiotics to children with measles, but actually we do for children who are at high risk of complications. So in the UK, in Europe, no, we wouldn't treat measles. It's a virus. We wouldn't treat them with antibiotics. We manage it with simple remedies such as paracetamol. But children who are at high risk of complications, so they have severe malnutrition or HIV, they very well require broad-spectrum antibiotics at the outset to prevent bacterial infections which will lead to death. So it's very different. So the context of measles is very different if you're in a lower middle-income country or if you've got children with malnutrition or AIDS. These are just a few of our systematic reviews from the Wales Centre, and I was just going to talk about how context influenced some of these reviews and some of our findings. So this was the first one. This was assistant at meal times in hospital settings. So as nurses, we used to feed patients. Now sometimes we don't. And now we have to have all these implementation to make sure we feed our patients. So we were looking at protected meal times. Did they work? A lot of places, they didn't actually, because what happened when you had protected meal time, what the nurses did was use the time to go in the office and catch up their paperwork. So they still weren't feeding the patients. So it was very, very difficult. What worked was when all the healthcare staff worked together. So it wasn't one particular strategy. It was about everybody working together to make nutritional intake a priority. And bringing people in to help patients with their meals, your visitors, your other staff, your volunteers. That's what worked. Another one, this was one of our Malawian students. She looked at the effectiveness of community-based nutrition education on nutrition status of under 5 children in developing countries. Nutritional status of children in all the studies improved with various projects, but there were varied results. And that depended, again, on the context. It depended on the nutritional status for the children. So possible reasons were actually the intervention strategies did vary. They varied in the strategy, the intensity, some were 2 weeks, some were 6 months, the age of the children at enrolment, the existing children's growth and nutritional status. So all those contextual issues all played a part. And then finally, this review here, this is one we're currently updating, the effectiveness of strategies and interventions to aim to assist the transition from student to newly qualified nurse. So when you're a newly qualified nurse, what helps you to transition into this role? So again, we included 33 studies, all very, very different. What we actually found from all those studies, for it didn't actually matter what the intervention was. So people had done these lovely RCTs, they'd done cohort studies, they'd done all different studies. What actually mattered is that the organisation did something. That when you qualify, they focused on the newly graduate role, nurse's role. They gave support to the newly qualified nurses. It didn't quite matter what they did, whether it was mentorship, preceptorship, didactic interventions, but most of the studies said it was about support from your colleagues as well as the organisations. So again, it was about that context. It wasn't one intervention, it was that whole context. So context is influential in a number of ways. So it can be culturally, financially, politically, or individually. So I wanted to just refer you to Mindlines. So some of you may remember this original study. It was done by Gabay and LeMay in the UK, came out in the BMJ in 2004, and they wanted to turn implementation on its head and say, yeah, we have all these clinical guidelines, we have all these things in practice, but still people are not using them. And they came up with something called Mindlines, which was based on the Aboriginal songlines that guide the Aboriginal people from place to place. It's in your head. And they said it's about knowledge in practice, in context. It's about communities coming together to make sense of things. It's about how you transform knowledge as a community. And actually, rather than think about specific barriers and formulas, what we need to do is think about what works. And actually, they were looking, so this study was in primary care, so they looked at GPs and practice nurses. And what they said was actually, having coffee breaks, coffee shop conversations worked, you know, deciding what you were going to do as a team. And there's a recent study again in 2016 where they've talked very much about this sort of coffee culture. We need to talk to each other and make a decision in our individual teams. So the way forward, so lots of talk now about realist methodology. So thinking about, you know, when you're doing your reviews or doing your studies, think about what works, for whom, in what respect, to what extent, in what context and how. And that's underpinned by the philosophy of critical realism. So based on mixed methods. So we're not thinking about quantitative studies and qualitative studies, but actually we want to know what works, who does it work for, and what influences that work. Okay. Dukuji. Dukuji? Is that Dukuji? Dukui? Dukui. Dukui. Thank you.
Thank you very much, Judith. Do we have questions for Judith?
Thank you very much. I'm very happy for your presentation and the previous one because, as all of you know, I'm mostly focused on nursing and the nursing profession and nursing, increasing knowledge in nursing. And we actually, for 4 years, have had similar project as in Spanish. So we are collecting data about adverse events from the whole country. And since this year, it will be obligatory. So we are very happy, but the content is really very important because you can do everything. You can implement lots of guidelines or guidance or suggestions, but if the nurses are only one who would like to implement it and the managers are not understanding it or they don't have enough money to do it, like for the prevention of pressure ulcers, how the poor one person could be harmed then, because there still is a problem that pressure ulcers are accepted as an indicator of the quality. And we know that we have avoidable and unavoidable pressure ulcers. So the context should be always been in our minds. So we are collecting data from all the hospitals, doesn't matter if private or the governmental one, and we are comparing the different types of hospitals, like faculty hospitals, small hospitals, long-term hospitals. So thank you once more. Your presentations and your views will be always a good argument for us when we are working with politicians, with managers, and we would like definitely collaborate with you and present you our work on national reporting system and national portal we have. Thank you once more. It's great.
Thank you, Andrea. Yeah, I think the reason I'm so interested in context is that my background, my clinical background was primary care as a practice nurse. So the patients we see actually had complex comorbidities. So the guidelines didn't work for them because research isn't done with patients with complex comorbidities. And I also ran a program for community nurses in Oman. And when we first went out to run this program, we thought district nurses in Oman will be the same as district nurses in the UK. Absolutely not. There's all these different things that impact. And one of the very key things was, we use something called 4-layer bandaging for leg ulcers, very effective, fantastic treatment. So we went over to Oman thinking we'll teach all the nurses about 4-layer bandaging. They'd never heard of it. And we were like, oh, and we thought, yeah, because it's 50 degrees over here, actually 4-layer bandaging, most of your patients are not going to tolerate it. So the context was very different.